Hello everyone, this is Anthony Chan. Welcome to my lecture series on essential medical liver pathology for trainees and any pathologists interested in liver pathology. In the previous lecture, we discussed two key pathological changes associated with necroinflammatory activity cellular damage and inflammatory infiltrate. In this lecture, we'll explore other key pathological changes. Let's get started with intracellular accumulation. Different intrahepatic depositions can occur in various physiological and pathological conditions, including fat, glycogen, intracytoplasmic and intranuclear inclusions, and pigments. Some of these intrahepatic depositions may be relatively specific to underlying diseases, for example, abundant accumulation of alpha-1 antitrypsin globules in alpha-1 antitrypsin deficiency. But in contrast, when combined with additional features, others can help identify the underlying causes, for example, macrovesicular steatosis, Mallory-Denk bodies, glycogenated nuclei, and giant mitochondria in steatohepatitis. Many hepatocytes display clear vacuolation in their nuclei due to glycogen accumulation, known as glycogenated nuclei. Another example shows many hepatocytes with glycogenated nuclei. Physiological hepatic nuclear glycogenation is common in children, adolescents, and young adults. Initially identified in patients with diabetes, pathological nuclear glycogenation is linked to metabolic dysfunction-associated steatotic liver disease, glycogen storage disease, Wilson disease, and other copper overload disorders. It is believed to be associated with impaired glucose tolerance or insulin resistance. Steatosis, or fatty change, refers to fat accumulation within hepatocytes. Macrovesicular steatosis is classically characterized by a hepatocyte containing a single large fat droplet that displaces the nucleus to the periphery. This is another typical example of macrovesicular steatosis. It is also increasingly recognized that, as triglycerides accumulate in hepatocytes over time, the lipid droplets can vary in size, resulting in a range of droplet sizes. These variations fall under the macrovesicular pattern of hepatic steatosis. We may describe these hepatocytes as small or medium droplet macrovesicular steatosis. This is another example of macrovesicular steatosis with varied size droplets of lipids. It is commonly found that hepatocytes contain small, medium, and large lipid droplets of lipids in macrovesicular steatosis. In contrast, microvesicular steatosis is characterized by hepatocytes filled with multiple small fat droplets, with the nucleus remaining central. Small droplet macrovesicular steatosis may morphologically mimic microvesicular steatosis, but it is usually accompanied by other hepatocytes that contain medium or large lipid droplets. For most pathologists, the term microvesicular steatosis is typically reserved for cases where this pattern diffusely involves the liver. In microvesicular steatosis, hepatocytes can contain multiple tiny fat droplets, which may be so small that the cells appear swollen with a fine foamy cytoplasm. This appearance can mimic ballooning degeneration, feathery degeneration, and glycogen-rich hepatocytes. While the oil red or stain can highlight these droplets, it requires a frozen section of the specimen, which is usually unavailable in routine practice. The major differential diagnoses of macrovesicular steatosis are alcohol-associated liver disease, metabolic dysfunction-associated steatotic liver disease, chronic hepatitis C, drug-induced liver injury, and Wilson disease. Microvesicular steatosis is associated with significant mitochondrial dysfunction and fatty acid oxidation defects, as seen in conditions such as Reye's syndrome, acute fatty liver of pregnancy, acute alcoholic foamy degeneration, and urea cycle defects. The term focal microvesicular steatosis should more accurately be referred to as small droplet macrovesicular steatosis, which is found in alcohol-associated liver disease and metabolic dysfunction-associated steatotic liver disease, particularly with higher disease activity and progression. Cholestasis, which can also be termed biliobinostasis, is the accumulation of yellowish-brown granular bile pigment in the cytoplasm or bile canaliculi of hepatocytes. This is also a clear example of cholestasis characterized by the accumulation of bile pigment in the bile canaliculi and the cytoplasm of hepatocytes. Additionally, a few Kupffer cells also contain bile pigments. A bile infarct is confluent necrosis in the liver caused by severe cholestasis, typically associated with acute biliary obstruction. Some bile ductules are distended by inspissated bile concretions, a condition known as ductular cholestasis. This is another example of ductular cholestasis. Ductular cholestasis is also known as cholangitis lenta. A study investigated 28 cases of ductular cholestasis, primarily in liver transplant recipients. Over 85% of patients showed clinical signs of sepsis with positive microbiology cultures. Mortality was high, with more than 50% dying during hospitalization and only 32% surviving at the last follow-up. These findings highlight that ductular cholestasis on liver biopsy is frequently associated with sepsis and a high mortality rate. Some ballooned hepatocytes contain deeply eosinophilic, ropey intracytoplasmic inclusions known as Mallory-Denk bodies. These inclusions were previously called Mallory bodies or Mallory hyaline. Another example shows ballooned hepatocytes with Mallory-Denk bodies. Although Mallory-Denk bodies are often found in ballooned hepatocytes, this is not always the case. Mallory-Denk bodies consist of misfolded and aggregated intermediate filaments, mainly cytokeratin 8/18 and proteins such as p62 and ubiquitin. Ballooned hepatocytes exhibit a loss of cytoplasmic expression of cytokeratin 8/18, with the remaining immunoactivity confined to their Mallory-Denk bodies. Mallory-Denk bodies can be found in hepatocytes with feathery degeneration in chronic cholestatic conditions. Alcoholic steatohepatitis and metabolic dysfunction-associated steatohepatitis are two major differential diagnoses when Mallory-Denk bodies are found. You may also have to consider chronic cholestatic disease, Wilson disease, and drug-induced liver injury. Many brown, refractile, finely to coarsely granular hemosiderin pigments are present in the hepatocytes and Kupffer cells. Hemosiderin pigments could also be present in portal macrophages, endothelial cells, and cholangiocytes in the portal tract. In this example, Pearl's stain reveals extensive iron deposition in hepatocytes, Kupffer cells, portal macrophages, and bile duct epithelial cells. To assess abnormal iron deposition in the liver, it is essential to determine which cells are primarily affected, the zonal distribution if hepatocytes are predominantly involved, and the severity of iron overload. Several scoring systems assess iron overload semi-quantitatively, considering factors such as zonal distribution, the lowest magnification at which iron granules are visible, and the percentage of affected cells. However, no system is universally accepted. I prefer using a straightforward scheme by Lisich to assess the percentage of involved hepatocytes and Kupffer cells separately. Predominant hepatocytic involvement is termed parenchymal iron overload, while Kupffer cell involvement is termed mesenchymal iron overload. A mixed pattern involving both hepatocytes and Kupffer cells in similar proportions can also be observed. Hepatic iron overload can be primary or secondary. Most forms of hereditary hemochromatosis typically present with parenchymal iron overload. Classical histological features of hereditary hemochromatosis include parenchymal iron overload, zone 1 predominant distribution, accentuation of iron deposits around bile canaliculi, and iron deposits in the bile duct epithelial cells. Ferroportin disease, a rare form of hereditary hemochromatosis, is associated with the loss of function of the ferroportin protein. It presents with a mesenchymal or mixed pattern of iron overload rather than a parenchymal pattern. African iron overload is another rare disease characterized by a mixed pattern of iron deposition and appears to be associated with an unknown genetic predisposition. Secondary iron overload can be due to various conditions. Defective red cell synthesis, such as in thalassemia, sideroblastic anemia, and myelodysplastic syndrome, presents with parenchymal iron overload. Transfusion-dependent anemia is associated with a mesenchymal pattern of iron overload. Many chronic liver diseases, including fatty liver disease, chronic viral hepatitis, and autoimmune hepatitis, can present with a mixed pattern of iron overload, especially in cases of advanced fibrosis. In fact, a mixed pattern of iron overload can also be observed in the late stages of other conditions. Orsin stain highlights few periportal hepatocytes with copper-associated protein, indicating chronic cholate stasis. Another example shows periportal hepatocytes containing copper-associated protein. The presence of copper-associated protein is associated with chronic cholestatic disease, Wilson disease, and other rare copper storage disorders. However, you should notice that any chronic liver disease with advanced fibrosis or cirrhosis could have copper-associated protein deposition due to impaired bile flow. Numerous ground glass hepatocytes are shown, characterized by their pale eosinophilic, finely granular intracytoplasmic inclusions, occasionally surrounded by a clear halo. The ground glass inclusions represent endoplasmic reticulum containing abundant hepatitis B surface antigen, which can be highlighted by Orsin staining and immunohistochemistry for hepatitis B surface antigen. Pseudo-ground glass inclusions may be found in glycogen storage disease type 4, Lafora disease, drug-induced liver injury, and immunocompromised patients on multiple medications. Ornstein stain highlights numerous ground glass hepatocytes. Similarly, immunohistochemistry for hepatitis B surface antigen also highlights numerous ground glass hepatocytes. This is an example of pseudo-ground glass inclusions induced by thioguanine. Several hepatocytes display large, pale eosinophilic, finely granular, ground glass-like intracytoplasmic inclusions, sometimes surrounded by a clear halo. This represents an extreme form of enzyme induction. Although cyanamide is a prototype drug associated with forming pseudo-ground glass inclusions, other drugs, including chlorpromazine, phenytoin, phenobarbital, and thioguanine, may also induce those inclusions. Numerous periportal hepatocytes contain lightly eosinophilic, globular intracytoplasmic inclusions. Alpha-1 antitrypsin globules can be distinguished from other eosinophilic globular intracytoplasmic inclusions by demonstrating intense positivity with PASD stain and immunohistochemistry. PASD stain highlights numerous alpha-1 antitrypsin globules. Except in abundance, alpha-1 antitrypsin globules are not pathognomonic of alpha-1 antitrypsin deficiency, as they can also appear in cirrhosis of other etiologies and critically ill elderly patients with high serum alpha-1 antitrypsin levels. Giant mitochondria, also known as megamitochondria, are eosinophilic oval or needle-shaped intracytoplasmic inclusions. They represent enlarged and distended mitochondria with paracrystalline inclusions at the ultrastructural level. Another example shows giant mitochondria. It is important to distinguish them from other eosinophilic globular intracytoplasmic inclusions, especially alpha-1 antitrypsin globules. Giant mitochondria, although not commonly found, are primarily associated with fatty liver disease. They may also be observed in conditions such as acute fatty liver of pregnancy, glycogen storage disease, urea cycle defects, and glycogenic hepatopathy. The liver is renowned for its remarkable regenerative capacity, capable of restoring about 3/4 of its mass within 6 months. In cases of mild to moderate parenchymal necrosis, mitotic division of hepatocytes suffices to replace cellular loss, resulting in architectural changes and some cytologic alterations. In severe parenchymal damage, stem or progenitor cells, believed to reside in the canals of Hering, are activated and replicate. This proliferation and the associated stromal response manifest histologically as the ductular reaction. Regenerating hepatocytes are organized into thickened cords that are 2 cells thick, whereas hepatocytes in a normal adult liver are typically arranged in single-cell plates. During the regeneration process, the hepatocyte plates thicken to twin cell plates due to the replication of regenerating hepatocytes. This is a liver biopsy from a patient with autoimmune hepatitis we've previously seen in the last lecture. Regenerating hepatocytes are arranged in rosettes or pseudoacini. During active regeneration, the hepatocyte plate becomes distorted, forming a rosette, pseudoacinus, or pseudogland. Hepatocyte rosette formation, often considered one of the typical histological features of autoimmune hepatitis, is actually a non-specific indication of active hepatocyte regeneration in the presence of severe inflammation. A mitotic figure is visible in a dividing hepatocyte, indicating a response to acute hepatitis. Hepatocyte replication through mitotic division is a crucial aspect of the liver's regenerative response, particularly evident in cases of mild to moderate cellular loss. Regenerating hepatocytes may exhibit binucleation, vesicular chromatin, and prominent nucleoli. Multinucleation may also be found occasionally. Ploidy can represent a stage of mitotic division telophase, serving as evidence of hepatocyte replication. However, binucleated hepatocytes are often seen in liver biopsies, particularly in elderly patients. These aging hepatocytes typically contain lipofuscin, unlike those undergoing active replication. The ductular reaction is the proliferation of bile ductules cholangioles within an edematous stroma and is associated with an inflammatory infiltrate, particularly notable for the presence of neutrophils. A prominent ductular reaction is present at the portal parenchymal interface. While commonly associated with biliary diseases, ductular reactions can also occur in various acute and chronic liver diseases and liver tumors. It is thought that ductular reaction results from the activation of hepatic progenitor cells, the self-proliferation of cholangiocytes, and the transdifferentiation of hepatocytes in response to various injuries to hepatocytes and cholangiocytes. When long-standing liver injury surpasses the liver's regenerative capacity, fibrous connective tissue is deposited, effectively scarring the damaged tissue. Fibrosis is a dynamic and bidirectional process driven by the balance between fibrogenesis and fibrolysis. It is important to identify the distribution and extent of fibrosis in the liver. The extent of fibrosis indicates the liver disease's chronicity or stage. Determining the degree of fibrosis is not always straightforward and can sometimes be quite subjective. Differentiating between a normal portal tract with no fibrosis and minimal or mild portal fibrosis can be challenging. Take this case, for example, if the sample were taken from a liver excision resected for a metastatic tumor in a patient without any chronic liver disease. Most, if not all, pathologists would consider it normal without any hesitation. However, if it were taken from a patient with known chronic hepatitis B, many pathologists might struggle to distinguish between normal portal tract without fibrosis and mild portal fibrosis. However, diagnosing portal fibrosis is much easier in the presence of short fibrous strands extending from the portal tract. Those short fibrous extensions are known as periportal fibrosis. Another example demonstrates portal and periportal fibrosis. This portal-based fibrosis, where fibrosis begins from the portal tracts, is associated with chronic liver diseases with predominant portal inflammation, such as chronic viral hepatitis, autoimmune hepatitis, and chronic biliary diseases. Perimular and pericellular fibrosis is characterized by delicate fibrous strands deposited around the central vein, extending into sinusoids and appearing to wrap around hepatocytes. This is another example of perivenular and pericellular fibrosis. This type of fibrosis is typically observed in fatty liver diseases, but may also be seen in conditions such as congestive heart failure, Budd-Chiari syndrome, and sinusoidal obstruction syndrome. Pericellular fibrosis, also called perisinusoidal fibrosis, involves the deposition of fibrous tissue in the space of disease and is linked to the activation of stellate cells. This type of fibrosis is typically seen in fatty liver diseases, but is also associated with fibrosing cholestatic hepatitis B and C and Wilson disease. As fibrosis progresses, bridge fibrosis develops. This more severe and chronic form of fibrosis is characterized by the expansion of connective tissue that links portal tract to portal tract and portal tract to central vein. Cirrhosis develops when fibrous septa surround regenerative nodules of hepatocytes. This is an example of cirrhosis. Pericellular fibrosis is still evident in this cirrhotic liver associated with metabolic dysfunction, associated steatotic liver disease. Biliary type cirrhosis is characterized by irregular regenerative nodules with a jigsaw puzzle appearance and a peripheral pale biliary halo, all surrounded by thick fibrous septa. It is associated with chronic cholestatic diseases. The peripheral halo in biliary type cirrhosis is formed by periseptal edema, loosely packed fibrous tissue at the interface, and periseptal hepatocytes exhibiting feathery degeneration. Periductal fibrosis is featured by onion skin concentric fibrous tissue encircling a bile duct. It is associated with the activation of peribiliary macrophages and the epithelial mesenchymal transition of cholangiocytes. Another example of periductal fibrosis is associated with portal fibrosis. Periductal fibrosis is characteristic of primary and secondary sclerosing cholangitis, as well as ischemic cholangitis. Great, we've covered all the essential pathological changes associated with liver injuries. Thank you for staying with us for this lecture. I hope you found it enjoyable. In the following lectures, we'll discuss various histological patterns by combining these pathological changes. I look forward to seeing you again.